Our next case is from Dr. Asghar Nawaz, who's from Manchester, UK. I believe he's come the furthest. I don't know, do we give a prize to whoever came the furthest to give the presentation? But he's this is an unusual case of thymoma invading superior cable vein, excised completely en bloc with superior cable vein resection and reconstruction. Dr. Nawaz, case number 4.
Good evening, everyone, and thank you very much, Mr. Chairman and the AATS committee for giving us this opportunity. It's a great honor. An unusual case of thymoma invading SVC, excised completely en bloc with SVC Resection and Reconstruction. My name is Asghar Nawaz. I'm a final year resident from Manchester, United Kingdom. I have no disclosures. So stage 3 thymomas, particularly with the SVC invasion, present a surgical challenge. Neoadjuvant chemotherapy following surgery and the adjuvant radiotherapy not only give the chances of R0 resection, but also improve the 5-year survival rate. So we report a rare case of stage 3 large 9.5 centimeter thymoma with SVC invasion, but no stridor, no SVC syndrome, and no mesthenic symptoms, in a 69-year-old lady who was otherwise quite fit and well. She responded very poorly to the neoadjuvant chemotherapy, so was referred for surgical resection. And as you can see, is a large tumor. Craniocaudally is measured 9.5 centimeter, and it is invading the surrounding structures. So we performed a complex operation via median sternotomy with cervical extension for better exposure, and en bloc resection of the thymic tumor with SVC, wedge resection of the right upper lobe of the lung, part of the pericardium, and the right phrenic was also sacrificed to achieve the complete resection. The cardiopulmonary bypass was on standby, but was not used, and we did not use the shunt and neither the systemic heparinization. But the patient was monitored with the cerebral oximetry throughout the procedure. And as you can see in this picture, the thymic tumor has been removed with the lung, SVC, and the innominate. Following the resection, the SVC and the left-sided innominate was then reconstructed by constituting a T-graft using the 15 millimeter non-ringed Gore-Tex graft. We first performed the end-to-side anastomosis by partially clamping the right internal jugular vein, followed by this end-to-side anastomosis with the right atrial appendage after excluding the pectinate fibers. This was done finally, followed by the end-to-end anastomosis of the left innominate vein with the horizontal T part of the graft. The operation was uneventful, from where she made a good recovery, and the patient was discharged home on the apixaban. And as you can see on the post-op CT, the graft is well seated and widely patent. And this patient was then referred back to the oncology for the consideration of adjuvant therapy, as the histopathology revealed it to be Massaoka stage 3, type B3 epithelioid thymoma, T3N0, with R1 resection due to microscopic tumor close to the resection margin. So in conclusion, we say with this novel technique, the surgery for stage 3 thymomas, which are invading the great vessels, is feasible, and we can get the good outcomes, and this should be offered to the patients who are suitable for this kind of approach. Thank you very much again, and I'm happy to take the questions.
start with Dr. Lukatic, who's an expert in this field. Jim, grab your microphone there.
I wonder if you could comment on which margin was positive and was that suspected intra-op? Because you have a number of margins here. You have vessels, you have pulmonary resection, you have the phrenic, pericardium. Where was the positivity?
It was positive actually more onto the vascular side where the SVC area was, but we could hardly go more proximally because we went really right onto the right internal jugular vein. And it was only microscopic, just close to the margin.
And you said consideration for radiation. Was radiation given post-op?
The radiation was given to the patient.
And can you tell me the size of the graft and the choice of not using rib? We have significant trouble keeping these grafts patent in this location. We've tended to go to the smaller size to enhance flow. So when you have this big boggy graft there, they tend to clot. They tend to clot when you have a big boggy graft, especially when they're not ribbed. I would say some of my colleagues, my cardiac colleagues, when we do these together, they prefer to do a spiral vein graft over a chest tube. Make it works very nicely as well. But that's a very big graft there. Why the choice of such 15 millimeter? I've never seen that before.
Yeah.
Do you have any evidence that it remained patent long term?
You're absolutely right. For the first thing is, yes, there are concerns because it's a low flow system. Obviously, you are concerned the blockage in consideration, and that's why we started the patient immediately after onto the apixaban. This was the immediate post-op CT, and the patient is still under follow-up. It was done recently during the last year, and we plan to do another CT scan. At the moment, I cannot tell you how the graft is doing, but looking at the first image, if I can go back, we pretty feel confident that this would be patent. And the other concern also we received when we were discussing this preoperatively, whether to do it or not, there was concern whether if we approach it through the median sternotomy, there's always concern that you may actually, especially the horizontal part, you may constrict it when you reapproximate the sternum. But surprisingly, as you could see on this, that is not true either. So I think it is probably, we will know by the long-term follow-up, but at the moment, so far, whatever follow-up we have, the graft was patent.
I see. And did you consider a hemiclamshell? When the tumor extends right or left, we tend to, on the right, we would have probably done a hemiclamshell. It just makes it a little easier for assessing margins, the phrenic, dealing with the lung, you have to resect the lung. So I just wondered if you'd considered extending it in a hemiclamshell approach.
No, really. The reason for that, we actually extended it to the cervical.
I saw that, yeah.
Yeah, because the large part of the tumor was craniocaudally. So, and we were concerned, whether we will leave anything. And as you can see from the histopathology, it was the vascular part where we thought there was a microscopic small areas. So I don't think.
So you had decent exposure and you were able to get it done.
We had a very good exposure.
That's the main thing.
Very, very good exposure.
Okay, thank you.
What were you going to do if the cerebral oximetry dropped? In other words, your venous drainage from the brain is obviously an issue in this case. Sounds like she woke up and was neurologically intact.
Yes. Yeah, she woke up neurologically absolutely intact. We did have obviously concerns, and that's why I mentioned in this that there was no. This concern is especially higher for the people who have got myasthenic SVC syndrome. She didn't have pre-op SVC syndrome, and during the process, the anesthetist was monitoring his face as well as cerebral oximetry. But if there was any issue, we had the cardiopulmonary bypass on standby. The other alternate option.
Which venous structure were you going to cannulate?
The other alternate option would have been to do a shunt from the right internal jugular vein right to the right atrium, so that you have a drainage. But surprisingly, we didn't need that.
Very interesting. All right. Any other questions? Okay. Thank you very much. Nice presentation.
Thank you very much again.
All right.